If there are none, I would request Dr. Deeksha Katoch from our department at PGI Chandigarh to give you a talk about RETCAM, how to interpret and what is normal versus abnormal. I have two announcements to make. One, Dr. Rima probably is not well, so I would request Dr. Mohit Dogra to be chairing the next session for Yulia. And the second one is there is a very interesting quiz that imaging team from Advanced Eye Center is going to show. So do not miss that. We will take that up immediately after the UVA session. Yes, Deeksha.
Suresh, Dr. Parul and the entire team at GMCH for this opportunity. Greetings to esteemed chairpersons, and please feel free to indicate the time for me, it is already late. So my topic is what is normal versus abnormal on RETCAM. So what is the RETCAM actually? These are the two variants of the RETCAM. One is the RETCAM shuttle and the other is the RETCAM 3. The RETCAM 3 just has an additional feature of the fluorescein angiography. So both are actually portable, ultra-wide field digital fundus cameras that allow you to capture 130 degrees of the retina. They are contact-based imaging systems. There is a handpiece with and there's the facility to change 4 lenses. One that gives you 130 degrees, then the 80 degrees, 30 degrees, and a portrait view lens. So both have this. The shuttle is the more compact one, and that is one which is more commonly used when you have to transport it between two NICUs. What is its use? The most common use is for pediatric imaging, and of all of that, the most common is for imaging preterms for retinopathy of prematurity. So where all can it be used? Within the NICU, in the newborn nursery, in the clinics, in the operating rooms when you are examining children under anesthesia, and very importantly for use in telemedicine when there is a shortage of ophthalmologists and you can capture images and transport them to remotely placed ophthalmologists for the interpretation. So quickly, just let me tell you what is normal. So just as when you're doing a clinical examination and examining the fundus, what are you looking at? You're looking at the optic disc, you're looking at the retinal vessels, okay, and you're looking at what's happening to the retina and choroid. Since we are now talking of, first we'll talk about the preterms, we're talking of retinopathy of prematurity. We lay special emphasis to what's happening to the retinal vasculature. So normal retinal vasculature should have dichotomously branching patterns, splitting into 2, then splitting into 2. So what is abnormal in retinopathy? Let's look at some of the morphological patterns. So if you see the picture here, what's happening? There is loss of the normal dichotomous branching. Instead, what are you seeing? You can't delineate which is the arteriole, which is the venule. There is increased meandering or tortuosity, and there is the presence of these closed vascular loops or shunts. In addition, you see that there is a vascular arrest. This is another patient, and you see that the vessels are not really going into the periphery that they are intended to go. Along with that, you're seeing a preretinal hemorrhage here, and you're seeing an intraretinal hemorrhage here. So this is what is aggressive ROP. The word posterior has been dropped from this, which was earlier called as aggressive posterior ROP. So basically just to lay importance that you're looking at the morphology, not just the location. So this is aggressive ROP now. What else are you looking at within the retinal vessels? You're looking at dilatation tortuosity, which is referred as the plus disease. So now plus disease, first the importance was to list that if it is more than 2 quadrants, it is important, but now no longer that is important. You are actually looking at the whole of the zone 1. I won't be going into details of the zones, you can read about it, but you're looking at entire changes in zone 1 to classify plus disease. One important thing between the previous and this picture, I just want to make you understand, is eyes in which aggressive ROP develop with more posterior. So the more posterior the disease, the thinner the caliber of vessels is being. So that doesn't mean that there is no plus, there is plus, but the caliber of the vessels will be thinner. So you don't label that this does not require treatment, it is going to require treatment. If you do a fluorescein angiography, which is available with the RETCAM 3, you are going to confirm your vascular obliteration, confirm the extent, document any new vascularization. Just like ma'am mentioned, it's going to show leakage. And also you see that though this vessel here, you are seeing a vessel which looks red, when you're doing the angiography, it is actually obliterated. So the exact extent of the vascular non-perfusion can be documented. People use it to guide treatment. For example, if the macula is not perfused, as in this case, they will tend to prefer anti-VEGF, and if it is perfused, they may go ahead with laser. The next is the morphological abnormality is the ridge, which is seen in the staged ROP. It is the hallmark feature. So what is it? It appears as a white structure at the border of the vascular and the avascular retina. When it is just flat, it is a demarcation line. When it has volume, it becomes the ridge. So these are both pictures which show the ridge, and you also have to look at the consistent vascular changes. So here they are less than what I showed before, so this is pre plus. Then this, if you look at the change, what's happening, look at what's happening at the posterior border of the ridge. You are seeing extra retinal vessels. You're going new vascularization, which is going into the posterior hyaloid phase. So this is ridge with extra retinal proliferation, and this is stage 3. These are also stage 3, different patterns of stage 3. What is this which is going in? Anyone? Quickly. So this is a stage 3 with a notch. This is the new terminology that has come up in the new classification. The importance of the notch is that the notch as a more posterior location, you are going to, when you are writing the classification, you will say this is posterior zone 2 stage 3 disease, but it is secondary to notch. So it will be different. The prognosis is going to be different from a disease which is entirely in posterior zone 2. The prognosis is better when a disease is secondary to notch in posterior zone 2. Okay. So then this is retinal detachments in ROP, which is stage 4 when it is not involving the macula, and 4B when it is involving the macula. Now again, these fractional detachments can be peripheral, which are more tent-like, but they can also be posterior, very posterior. In fact, they can be peripapillary, and they may be peripapillary and the proliferation may reach right up to the lens. Again, the prognosis is slightly better with the peripheral detachments compared to the posterior ones. Then these are the total retinal detachments. Mind you, retinal detachments in ROP can be exudative, rhegmatogenous, and tractional. Here is an example of a rhegmatogenous retinal detachment. And for more details, please go back and read the latest revision of the ICROP classification. Another important morphology abnormality which we see and document often on the RETCAMs is presence of retinal hemorrhages. Different patterns from the vitreous, pre-retinal, intraretinal, subretinal hemorrhages can be seen when we are imaging children. So there are a lot of causes, and you have to remember sometimes vacuum assisted delivery, prolonged second stage of labor, non-accidental injuries should come to your mind, and you should examine the child as a whole. Anemia and sepsis have to be ruled out. We have also seen Dawson syndrome in the infantile period. Sometimes when the hemorrhage is in the vitreous cavity, often these children are also referred to as endogenous endophthalmitis or retinal detachment, though actually it's just a vitreous hemorrhage and they respond well to surgery. Again, common reference for all of us is cherry red spots. And you see this pattern, this is classic, then you have to document and then refer back to look for glycogen storage diseases. Another important use of the RETCAM is in the management of a retinoblastoma, where it is used to photographically follow up patients before and after treatment. Then is Coats disease, classically presenting with retinal telangiectasias with exudation. On fluorescein angiography, this is done on the RETCAM. It is going to show typical retinal telangiectasia showing the light bulb appearance. Advanced stages can present with a total exudative retinal detachment, can reach up to the lens. A good clinical examination can often show these retinal telangiectasias, and this type of picture can frequently be confused with a retinoblastoma. So a good examination is important. Then we have another entity where you have sometimes retinal detachments beginning within the first year of life, or you may have children presenting with these kind of folds. So on the angiography, you see a vascular arrest, predominantly involving the temporal retina, neovascularization. There may be proliferative vitreoretinopathy. So what's the diagnosis? Yeah, so this is FEVR. This is an autosomal dominant inheritance. And these are generally term babies. So it's important that you examine the family as a whole. just in the interest of time, other entities are retinal choroidal dystrophies, congenital anomalies such as colobomas, and systemic diseases with ocular manifestations. This is a hereditary dystrophy. This is X-linked retinoschisis. Dr. Simmer talked about it on the OCT. So this is the bullous variety of the retinoschisis, again bilateral presentation. So this another is a rare case actually. So what happened was this child was referred for examination, and we looked at this chorioretinal atrophic changes, and we documented on the RETCAM, and we shared with the pediatrician that this is what we are seeing on the RETCAM. So when the pediatrician examined the child, she found that the child had lymphedema, the child had microcephaly. So when 2 and 2 were actually put together, it came out that this child probably has a rare K1F11 gene mutation. So that's how it can help both the ophthalmologists as well as the pediatricians. Just to mention that a low cost and indigenous version of the RETCAM, which is made by Forest Health, is available. And initially it had only the imaging, but now they have come up with the fluorescein angiographic feature in the latest model. So I think this is a huge benefit for low socioeconomic status countries like India, because it's almost like half the cost of the RETCAM. Thank you for patient hearing.
Thank you very much.